This video is going to look at the biological therapies for schizophrenia. When we're talking about biological therapies, we are talking solely about drugs. So, there's two main types of drugs you need to know on your specification: typical and atypical antipsychotics. So, antipsychotics can be taken in a variety of different forms. Some people take them as tablets, some as syrups, some as injections, and they can be required in either the short term or the long term. And what they're really used for is to help patients to function with their everyday life, to undertake tasks that schizophrenia might otherwise prevent them from doing. And they are the initial form of treatment. So any schizophrenia patient will be initially treated using antipsychotics. And after that, it's then combined with different forms of therapy. And they all work by reducing the effect of dopamine on particular areas of the brain. That's how they work. It's all linked to that dopamine hypothesis we've already learned about. So first we're going to look at our typical antipsychotics. And these are sort of the first generation or the traditional drug. Came out in the 1950s. Okay, so typical antipsychotics are the first ones that came about. And the big one we're going to look at is chlorpromazine. And chlorpromazine is an antipsychotic drug that's given, and the drug dosage is gradually increased until you get to a maximum dosage of 1,000 milligrams. So it's a gradually increased drug. And there's a strong association between chlorpromazine and the dopamine hypothesis. But chlorpromazine acts as an antagonist for the dopamine system. An antagonist just means it reduces the action of dopamine in particular areas of the brain. And it works in a certain way. What it does is it blocks the receptors in the synapse of the brain. It blocks those dopamine, those D2 receptors in the brain, which reduces the action of dopamine. We'll have a look at a diagram next to show you exactly how that works. And what this does, this blocking of the dopamine receptors, it just normalizes and neutralizes dopamine in key areas of the brain. And that reduces the positive symptoms of schizophrenia, like hallucination. So typical antipsychotics are really there to treat the positive symptoms of schizophrenia. So if we have a little look at this drawing here, you've got the impulse coming down into the presynaptic cell, and dopamine starts to be released here in this little area from the vesicles. Dopamine gets released. But you can see these little blue dots right there on each of the dopamine or D2 receptors, and that is chlorpromazine. And chlorpromazine, once it lands on that receptor, dopamine can't land on it, so it blocks the action of dopamine. That means it blocks that neuron and that synapse from firing and the action potential in the impulse carrying on down the postsynaptic cell. So chlorpromazine is there solely to block dopamine landing on the receptor. Again, another picture here. So you've got the antipsychotic, you've got chlorpromazine here, these little red balls, already on the dopamine receptors, these D2 receptors. So dopamine gets released, but it can't land on the receptor, and therefore the impulse can't carry on down the postsynaptic neuron. And that is how it neutralizes and normalizes dopamine activity in the brain. Remember, schizophrenia is caused by increased dopamine levels, that rapid firing in the synapses. So all these traditional antipsychotics do is stop that firing from being able to take place and blocking the dopamine receptors. So one of the problems though with these typical antipsychotics is that 75% of the receptors must be blocked for the drug to be effective. And this can lead to really bad side effects that we'll look at when we're doing the evaluation point. Chlorpromazine is also a very effective sedative, so it can really calm people down, knock them out a bit. And it's often used when schizophrenic patients are admitted to hospital, they're very anxious, very worked up. Chlorpromazine will be given to them simply to sedate them a bit. So we've looked at traditional and typical antipsychotics. Now we're going to look at atypical antipsychotics. And these were developed in the 1970s, and really they were to be more effective and also to reduce the side effect of the traditional antipsychotics. And they improve everything. They improve positive, negative symptoms of schizophrenia and also help with cognitive impairment. So they've got far wider reaching benefits than your traditional or typical antipsychotics that only work on positive symptoms. So how these ones work and how they reduce the side effects is they only temporarily block the D2 receptors. They'll land on a dopamine receptor, block it, and then leave quite quickly. Okay, and that really reduces the side effects. One of the most famous and most popular atypical antipsychotics is clozapine. And clozapine works by being slightly more effective than any of the typical antipsychotics. And it's used when all other treatments fail. So when all the other treatments have failed, all the other antipsychotics have failed, people will be given clozapine as the next alternative drug. However, they do have a side effect, okay? Agranulocytosis. And what this does is it increases the patient's risk of infection and can eventually be fatal if it's not treated. So it does have quite a big side effect, but it is a very, very effective antipsychotic. So we're going to look at clozapine in a little bit more detail. What it does is it binds to those dopamine receptors, but it also binds to serotonin and glutamate receptors as well. So it's blocking far more receptors on that postsynaptic neuron. And because it's increasing serotonin levels in the brain, it does improve the mood and reduces depression that a lot of schizophrenics have. And it also improves their cognitive function, their ability to solve problems. And it's also prescribed when the patients are at a very high risk of suicide. About 30 to 50% of schizophrenic patients will attempt suicide at some point. So these antipsychotic is needed because it improves mood and reduces depression, because they're the things that are going to lead to suicide eventually. And also, because it focuses on serotonin and glutamate as well, it has less effect on the dopamine system. The more dopamine system and receptors that are blocked, the more effect that has on someone's bodily movements. Dopamine is very, very important in movement control. So because it has less effect on it, because it's focusing on other neurotransmitters as well, it also affects all the physical problems that schizophrenics get while they're on atypical antipsychotics. So the second atypical antipsychotic is risperidone. And what this was developed in the 1990s. And it wanted to be as effective as clozapine, but to have less side effects. So once you take this drug, it lasts for 2 whole weeks. So you see the benefits straight away. It's going to be less time consuming. You take one drug, you get the effects for 2 weeks. And what it does is it binds to dopamine and serotonin receptors. But it binds really strongly to dopamine, far more strongly than clozapine will do. And what that means is it's really effective in small doses. And because it's only taken in small doses, it has far less side effects than other drugs. So looking here, this here would have been, the yellow one, would have been the older medication, the typical antipsychotics. That would land on the receptor, here, land on the dopamine receptor, stay there, and slowly be removed. Okay, and when it was staying there for a long time on the dopamine receptor, that's when we would have had all the other issues, all the side effects that came with those drugs. But now we've got these new atypical antipsychotics, the blue ones here. And what they do now is they land on the dopamine receptor here, and they very, very quickly leave. So they block the action, leave. And because of that, we get far less side effects. So now we're going to have a look at the AO3, the evaluation for these drugs. And you'll know some of these points already. So, always start with the general drug paragraph. You should know these points from last year. Drugs are cheaper than therapy. They're more accessible to a wider population. To engage in therapy, sometimes you need a high IQ. For drugs, you don't. And also, it's less disruptive to your life. You'll have to go for hours of therapy a week, disrupting your day, disrupting your life. Whereas with drugs, you're just popping a pill in the morning, once a day or once every 2 weeks, and it's far less disruptive to people's lives. However, you still do get side effects, okay? Things like weight gain, dizziness. Because we're affecting dopamine, you can get issues with movement. So some people get involuntary facial movements where they'll grimace or get jaw lock. You can also get very, very serious side effects as well. If we block dopamine receptors in the brain, then it can lead to things like high temperature, delirium, people could go into comas, and it could eventually be fatal. But obviously we get less side effects with atypical drugs. Okay, the more serious ones like blocking the brain dopamine receptors are more typical antipsychotics. But atypical ones have far less side effects. However, you can still get side effects. Like we said, that blood disorder, agranulocytosis, where you get increased risk of infection. And again, those people who are on these drugs will need regular blood tests to check they haven't got the disorder. Again, they can be addictive. People have to take them. And also, it's very questionable whether people can give their consent to taking these drugs. If you're schizophrenic, it's not quite clear whether you are mentally well enough to give your full consent to taking the drugs. So there is an ethical issue there as well. And finally, the drugs may just be suppressing the symptoms. They might not be treating anything at all. So they're simply suppressing the symptoms, but not actually treating the cause of the problem. So studies have been done that looked at antipsychotics versus placebos, and Thorney reviewed all the studies that looked at chlorpromazine versus placebo. There are 13 different trials in this meta-analysis with over 1,000 patients, so it is quite a large sample size. And what he found was that chlorpromazine had better overall functioning, reduced symptoms of schizophrenia, and had lower relapse rates. So clearly, chlorpromazine is far more effective than placebos. Support for antipsychotic comes from Meltzer's study, where he looked at clozapine, and he found that it was effective in 30 to 50% of treatment-resistant cases who had been resistant to typical antipsychotics. So these patients had failed on typical antipsychotics, but clozapine and the atypical antipsychotics were effective in up to 50% of those cases. So it shows antipsychotics are effective in reducing the symptoms of schizophrenia. One issue is that antipsychotics do depend on this dopamine hypothesis. They all work on normalizing dopamine levels in the brain. However, current research seems to suggest that dopamine levels, if they're too low sometimes, might also cause schizophrenia. If this is the case, then it's not quite clear how antipsychotics work, because antipsychotics are all about reducing dopamine levels in the brain. So if schizophrenia is caused by low levels, and we're lowering the levels using antipsychotics, then our current understanding of the role of dopamine is that antipsychotics shouldn't really work. So that's a major limitation of this particular theory. There's also problems with the evidence. Healy went on to say that all the successful trials have had their data published over and over and over again, so the effects of antipsychotics actually been vastly exaggerated. And that the studies only focus on the short-term benefits and short-term effects. We're not aware of the long-term effects of antipsychotics. And he also went on to say that antipsychotics have such a powerful calming effect. Remember I said before, some of them are quite strong sedatives, that it's quite easy to demonstrate positive effects on a patient. You give the patient the antipsychotic, acts as a sedative, calms them down. It's quite easy to show it having a positive effect. But that is by nowhere near the same as saying that you're actually reducing the severity of their psychosis. You're not dealing with the real issue. Maybe we're just seeing positive effects because that person's being sedated.